Hi, it is such a pleasure to be a sponsor of this year's SCCT Prevention Symposium. I'm very honored to speak with you today about the evolving role of advanced plaque analysis in preventive care. I'm Todd Villines. I'm the Chief Medical Officer of Elucid and a Professor of Medicine at the University of Virginia. And so this is where we were. Think back to 2005 with the advent of 64-slice CT scanning. And at that time, this was considered the holy grail, the ability to non-invasively assess for coronary stenosis. Of course, the goal of functional tests at this point in time had been to identify high-risk stenotic coronary disease. And so this was a very prescient statement, how to stop a heart attack before it happens. And of course, it assumed that if we found stenosis, that we could treat stenosis and prevent cardiac arrest and myocardial infarctions. But what we have learned since then and taught to us by CT angiography in large part is the importance of atherosclerosis. That is, in fact, the plaque, the root cause of the majority of heart attacks and strokes, the atherosclerotic process, the burden and type of plaque that we have that is the primary driver of risk. And coronary CT angiography can give us obviously stenosis, but so much more to advance the care of our patients. Now, we as a group are going to be seeing a lot more patients in our practice, even if you don't read coronary CT angiography with the results of this test. And it's because of international guidelines. Here, the 2021 multi-societal guidelines, the chest pain guidelines, elevated coronary CTA to the only Class 1 level of evidence A non-invasive test for the diagnosis of coronary disease. It incorporated FFRCT as part of the CT diagnostic pathway, and importantly, redefined clinical coronary artery disease based on CT identified plaque. And as this population grows, we as a community owe it to our patients to utilize this data to better care for them and to prevent life-altering events. Now, we've seen, of course, this dramatic increase in the use of coronary CT. This is data from Jonathan Weir-McCall from the UK. If you recall, the NICE guidelines went into effect in 2016, which promoted coronary CT as the preferred first-line test for most patients with stable chest pain. And what we've seen is an exponential increase in the use of coronary CT, a decline in functional testing. And this, at least from an associated standpoint, has not led to any worsened outcome. In fact, mortality related to cardiovascular disease has actually declined during this same period. And as all of you are aware, the real value, in my opinion, of coronary CT angiography is its ability to identify not only high-risk stenotic disease and not to miss disease, but to identify plaque. If we look into the PROMISE trial, the NHLBI-funded multi-center study that compared functional testing versus coronary CTA, we can see a difference in functional testing and CTA. For example, in functional tests, the majority of events occurred in a completely normal functional test. Nearly 60% of events were patients who were told they were fine. In coronary CTA, obviously, that was not the case. Almost all events were in patients with atherosclerosis, and very few were in patients with normal coronary arteries. Again, highlighting the ability of coronary CTA to refine how we manage patients after testing for coronary disease. Again, this concept that you simply cannot treat what you do not see. Now, how does advanced plaque help us here? Because we can obviously see areas of disease. We can semi-quantitatively and even quantitatively assess stenosis. How does advanced plaque help us? I'm going to walk you through how I think the field is changing. And we know that plaque is now taking a central role. We see on the left here an expert consensus statement from the SCCT, highlighting that it is in fact plaque that is the largest predictor of risk, and the importance that plaque plays in how we manage patients as stated in this document. I encourage all of you to take a look at it. We know that in the recently updated CADRADS 2.0 document, for the first time, a plaque score was recommended to be included in the conclusions for all patients who undergo coronary CT. Again, highlighting this importance of not just reporting stenosis, but combining that with assessment of overall plaque extent, as well as comments on plaque vulnerability. Now, how does advanced plaque analysis using software like Elucid's help us, or other software help us? Well, we've learned that our current reading paradigm, where we take in coronary CTA data, we assess stenosis semi-quantitatively, we comment on the dichotomous presence or absence of high-risk plaque is good, and it's better than functional testing, but there's a lot of information that we're leaving on the cutting room floor. We know that manually it's a laborious process to measure plaque in a manual way, and that advanced machine learning-based algorithms give us the ability to truly measure all of the disease that we see and to characterize it in a way and quantify it in a way that adds to our predictive abilities, our ability to convey to the patient what is their true risk. We learned this early on in the Scott trial. This is a trial that I'm sure is all familiar to you. And in this trial, automated plaque analysis was done to assess overall plaque volumes, as well as the volumes of different types of plaque, for example, low attenuation plaque. And what was shown in this study, which is important, is that low attenuation plaque was the strongest predictor of incident MI. It was irrespective of coronary artery calcium score, stenosis, and risk factors. And we saw the significant separation of risk if you had a lot of low attenuation plaque, if your low attenuation plaque burden was greater than 4%. And I think this study highlights the potential of using plaque quantification. It's there in a scan we've already done to measure what we see and to relay that into potentially differences in therapy. We know, for example, in the Paradigm study, this was a study of over 1,000 patients with repeat coronary CT angiograms at a median interscan interval of 3.3 years. That when you ask the question, what is the biggest predictor of plaque progression, irrespective of baseline medical therapy? And in fact, in this study, the authors defined rapid progression as greater than or equal to 1% annualized increase in percent atheroma volume. And again, the biggest predictors were volumetric measures of plaque, things we're not currently measuring, but we have the ability to measure. Things such as percent atheroma volume, total plaque volume, plaque burden, and other measures of plaque volume. These were clearly superior to clinical risk factors and qualitative measures of high-risk plaque that we're currently reporting in CAD-RADS, and clearly better than stenosis alone. Now, it's important to understand the limitations of plaque quantification. One of them is the influence of tube potential on the Hounsfield units that we measure in the wall. And so this highlights the potential limitations of using a strict Hounsfield unit-based measure of plaque types. We know, for example, and this is data from the Paradigm study, where patients were imaged at a variety of KVs, and that with lower tube potential, you get this increases lumen intensity, and this directly due to partial volume effects affects the Hounsfield units that you measure in the wall of the artery. And what you see at lower KV, for example, is increased measurements of calcified plaque and decreased volumes of low attenuation plaque. And it's important to understand these limitations when we think about how software performs in our patients. And these should be considered when you interpret Hounsfield unit measures of plaque volume. And so here at Elucid, how do we quantify plaque? Well, the first thing is that we do not use a strict Hounsfield unit scales due to those limitations. But we also attempt to identify and characterize plaque in the way that all of us learned this in medical school, as if pathologists were looking under the microscope. And the reason for this is not only these Hounsfield unit limitations, but it's the fact that things such as lipid-rich necrotic core, the highest risk plaque, the predominant type of plaque that leads to thin cap fibroatheromas and events, has a variety of Hounsfield units. It has heterogeneous appearance on CT. And so we have done this a little bit differently and attempted to create an algorithm that can identify patterns on CT that correspond to these various biologically based plaque types. So how did we do this at Elucid? Well, the first thing was to try to get very high quality atherosclerotic tissue that was not degraded, tissue that was well annotated and of the very highest quality. So we partnered with Renu Vermani and the team at CV Path. And it was felt that the optimal way to train a machine learning algorithm was to get these very high quality samples that can be achieved from carotid endarterectomy in patients at multiple centers who had undergone CT angiography. Using these high quality pathology slides, pathology specimens, cross sections were created, and each cross section was annotated for the presence of lipid-rich necrotic core, intraplaque hemorrhage, carotid plaque, and fibrous and fibrolipid plaque. These were paired with cross-sectional CT angiogram images and then used to train a machine learning algorithms. Again, not defining plaque strictly by Hounsfield units, but recognizing the patterns on CT angiogram that correlate best to these histological samples. And how did they perform? Well, you can see very high performance for the measurement and for the identification and quantification of these different plaque types. And so this is, I think, important work when you consider plaque software and asking the question, what is the validation standard? And in this case, instead of using Hounsfield units or humans, we used histologic validation. And this question I often receive is, well, how does this compare to coronary imaging? Well, we've now done studies where we see that it correlates well. This is a validation study where intravascular ultrasound and NIRS catheter was used to measure total atheroma volume, percent atheroma volume, as well as plaque volumes. And we see a strong correlation using the Elucid software to intravascular imaging for plaque volumetric assessments. We've used this software as well in important plaque progression and regression studies. This is a study from the NIH and Nehal Mehta's group, where the Elucid software was used to assess changes in plaque over 1 year of follow-up in patients with psoriasis, an inflammatory condition associated with higher rates of atherosclerosis and atherosclerosis progression. And in this study, we were able to show that with active therapy, regression of lipid-rich necrotic core was seen compared to placebo. So how can plaque change care? Well, I think, as all of you can appreciate, that better assessing risk can help you choose the optimal therapeutic intensity for patients. And what's great about today and the ability to use plaque is that we now have over a dozen therapies that have been shown to meaningfully impact and reduce cardiovascular events to choose from. And I think plaque can be at the center of that choice. I also think it can help for better patient engagement, showing patients their images, describing to them how the biology of plaque and how these plaques are different with regards to their future risk, and how that can lead to better medication adherence and perhaps lifestyle changes. In patients who have intermediate FFRCT, I think that plaque can really help us decide which patients truly may benefit from PCI and which patients perhaps with stable plaque can be treated medically. So the question is, can plaque quantification lead to better ischemia assessment? And this is something we're working very hard at Elucid to show. This is data from a study in 2015, which asked the question, in patients with abnormal invasive FFR, what did the patient's CT angiograms look like? And were there adverse plaque characteristics that were associated with these abnormal invasive FFRs? And what we see that stenosis alone was relatively poorly predictive, but it was in fact when you added in percent atheroma volumes as well as plaque characteristics that you see a much better prediction of ischemia. This concept that is in fact the amount and type of plaque in the wall of the artery that predicts ischemia. And this has been known for some time. And this concept that is in fact the amount and type of plaque that directly determines the coronary endothelial function and its ability to vasodilate in the cath lab when measuring FFR or under stress is something we've known for some time. This is a study back from 2013, which directly showed that it is high lipid containing plaques that are most associated with abnormal invasively assessed endothelial function. This concept that we've known that it is an active biological milieu in the wall of the coronary artery that has inflammatory mediators. It has active inflammation, foam cells, macrophages, and that this wall of the coronary artery is in fact biologically active and affects the endothelial function and affects the vasodilatory capacity of an artery. And this has led to the concept that in fact to predict invasive FFR using FFRCT, that models that incorporate plaque can perhaps do better. This is data from the Credence study showing that in fact you can build a model based on plaque and stenosis that performs as well as, to the right, a computational fluid dynamic based model. And so this concept that is in fact plaque that drives ischemia. And this is some very early work that we've done at Elucid, in fact, showing this feasibility. This is a single site feasibility study of 113 patients. This is a vessel-based analysis using the histologically defined Elucid plaque software. And using this software, you can identify features that in fact predict invasive FFR abnormalities with very high accuracy. Here you can see in a training and sequestered set, this feasibility study showing that you can use advanced plaque analysis to build very accurate models for predicting an abnormal invasive FFR. And so this is some of the work that we're currently working on that we hope to share with you later this year, which is the elucid novel plaque-based FFR-CT algorithm that we believe is an advance in the field and allows us to incorporate the plaque that we see, the type of plaque in the wall of the artery and its known effect on endothelial function and vasodilatory reserve to better estimate invasive FFR. Now, can we go beyond coronary plaque? We know there are literally thousands of CT angiograms done of other parts of the arterial tree. And can we do that? Well, what's unique about Elucid is that we are FDA cleared for use for plaque analysis in all arterial systems, and our software can process those for you. We know that there's significant potential in the carotid artery system. We know that 1 in 5 strokes are related to carotid atherosclerosis that results in plaque disruption and atheroembolism, and that even compared to the coronaries, it isn't truly plaque, this plaque risk over stenosis alone that we know drives risk. Unfortunately, revascularization guidelines are all based on percent diameter stenosis, and we have very good histologic and MR angiographic studies that have shown that it's in fact plaque morphology, things like plaque volume, intraplaque hemorrhage, and lipid-rich necrotic core that are clearly superior to stenosis for major adverse neurologic event prediction. And a high proportion of patients with abnormal carotid ultrasounds undergo CT angiography. The potential for us to utilize these scans to better predict risk, because we know that asymptomatic patients with carotid stenosis have low event rates, but some patients obviously will progress to stroke. And this is some registry data showing that, in fact, using the elucid analysis to quantify and characterize plaque is superior to stenosis for predicting patients who have events. This is a multi-center registry where patients followed a median of 18 months following CT angiography for a variety of stenotic degrees of severity. So this concept in the carotid space that we can use plaque to better assess which patients should be followed more closely and which patients should be offered revascularization, particularly in the setting when we have better medical therapies that can potentially stabilize plaque. And so assessing not only baseline risk, but potentially response to therapy in our carotid stenotic patients. And so this is the goal of the Elucid software, and we hope to partner with many of you in offering a plaque-based FFR-CT as well as a clinically available plaque analysis for your patients who undergo coronary CT. And this is just showing you the pathway that in patients where coronary CT angiogram is ordered, in patients who undergo that test, who have intermediate stenosis, that once FDA cleared, we could offer you a plaque-based FFR-CT product as well as whole heart coronary atherosclerosis assessment that includes stenosis quantification, plaque characterization, and plaque volumetric assessments. And so stay tuned. This will be an exciting next 12 months for Elucid, and we're really thrilled to sponsor this symposium and hopefully work with many of you going forward as we continue to develop this important product. Thank you.